Hi, good afternoon, everyone, and a very warm welcome to New Orleans. My name is Mike Scott. I'm the current president of ERAS USA.
And my name is Matthias Stopfkuchen-Evans for the program committee of ERAS USA. My warm welcome to all of you as well.
So it's just wonderful to be here in person. It's a small select group, as you know. We're limited with numbers this year, and people weren't really sure whether we're going to have the Congress or not. So I really appreciate everyone for making the effort. It's been 2 years now, and I really see this as a Congress to really kickstart ERAS again, because there's been this lull over the last 2 years, and I'm sure everyone here will be very willing to focus on this. As the organizing committee, we made a policy that we're not really going to talk about the pandemic for this whole Congress, although it still remains actually very relevant. Because ERAS still has an importance in delivering healthcare in the post-COVID era. For those of you who've never been to an ERAS Congress before, I feel I should at least tell you what we're all about as a society. What Enhanced Recovery is all about. It started in Europe. Henrik Kellett has been given really the grandfather rights on it, but there were many of us in Europe doing it from about 2001. And really what it is trying to get a patient's perioperative surgical pathway plan to reduce stress, again, improve the metabolic response and maintain body homeostasis, which then ends in a better outcome. And there was sort of this pillar of about 20 components which have been found, and all of those are relevant for most surgeries. But as we advance, we are also producing procedure-specific elements. So this is from the new textbook that we've got, and it shows really along the bottom you've got optimization, injury reduction, and protocolized de-escalation. And all the elements have different time bases through the pathway. And of course, different procedures need different parts of those elements. So analgesia for hip replacement is very different from that for abdominal laparoscopy. But what ERAS does bring is all these different things. It's one of those things which is a bit of a no-brainer. We know it doesn't cost a lot to implement, but it's difficult to implement. It is the application of evidence-based medicine. You improve your patient outcomes, you reduce complications, you decrease length of stay, and importantly also reduce opioids. And it's patient-centered and equitable. And ERAS USA is part of the global ERAS society, which we also have very good representation of on both Tonya and I. And the mission is to improve perioperative care and enhance post-operative recovery through implementation of evidence-based practice, audit, education, and research. And central to the mission is a culture of inclusivity and recognition of the importance of multi-professional and multidisciplinary collaboration. And it's this multidisciplinary engagement which I think makes us a unique society, and it's still very necessary. And I think we know that there's between 15 to 20% of loss of nursing, APPs, and paramedical staff. And it's so important to keep everyone focused and feel part of the patient's care pathway, because if not, we're going to lose more people from healthcare. So ERAS is very important from that perspective moving forward. Now, as a board, as a society, we have a constitution and a board, and I'd like to thank all these people for representing us. And if you'd like to be involved, just let us know through the next few days. We're a very approachable board. Just come up and meet everyone and at the end of sessions, and we're very happy to introduce you. We also have, through the ERAS Society, have an implementation and audit system, and Tonya Young-Faduk is in charge of this, and we've had some very successful implementations across whole healthcare systems. We've also been key for the Office of National Drug Control, with the Office of the White House, as a core pillar to reducing opioids perioperatively, but also obviously take home and diversion. So this is one of the key national focuses to reduce opioids and all the issues associated with that. As well as that, ERAS remains a core for the HRQ guidelines and the American College of Surgeons rollout, and I was involved with the Hopkins group for that and Lisa Wicks and co. So you can see we're having a big impact even through the pandemic, and we are evolving. We've got lots of subgroups, pediatrics, thoracics, so we're trying to offer something for everyone. Again, driving the evidence base more procedure specific. We're looking at partnershiping other organizations, the American Society of Regional Analgesia, we're hoping to do something this year. And even in the operating room, we've managed to penetrate the OR Manager series with 10 articles the whole of last year from VCU, Virginia Commonwealth University. We had a whole range of articles dealing with ERAS, implementation, audit, value, and equity. So as a society, we are trying to grow membership, so please get the word out there. We're trying to offer value. You get the ERAS Global membership included. We can network, you can career develop, mentor people. As well as that, we've got a website which is growing. We've got Problem of the Month series. We've got the ERAS Society book that you can do, which is a fantastic reference for perioperative medicine, no matter what surgical specialty, no matter what, whether you're an APP, a physician, or a nurse. And then, of course, we've got the annual Congress here at New Orleans. And also we have the world one, and it's just been announced that we're going to hold it in Madrid on the 1st to the 3rd of June in 2022. So hopefully you might get to that one as well. Our guidelines have been core for the society, and these ones where Carol Peden and I, you'll meet Carol shortly in the brain health section. This was in the 98th centile of publications when it was released. So you can see that our publications are having very, very high impact, and you'll see the citation factors are very high. And as I said, really, I think ERAS is still important in the future, in the era of COVID and post-COVID as we get out of it, to delivering value-based healthcare, patient-centered pathways, multidisciplinary working because of the reduction in complications and length of stay. Finally, I'd like to thank our past president, Dionysius Vrochides, who is actually giving a lecture on Friday. He steered the society through a very difficult time in the pandemic. The ERAS board and committees for doing the same thing, and I've listed them previously. And then the Congress committee members, Misty, Alison, Matthias, and Rich, for helping get this Congress together, which has had its own challenges. And PRRI, who are our organization that helped run ERAS USA and the annual Congress, Aurelie, Sarah, and Heather. And without them, it would have been very challenging, actually. It's been difficult for all small societies this year. And also, the other thing is without industry help, a lot of societies in the USA would be in big trouble now. So I'd like to mention 3M for their Gold Plus sponsorships, Bodax Bio for their Gold sponsorship, Abbott and Heron for Bronze sponsorship, and Pacira for their educational grant, as well as all the other industry sponsors outside. So we've got ACRX, AtriCure, Edwards Life Science, Merck & Co., Nestle, and Spinology and Twizzle. They're supporting not just the ERAS Society, but all the other societies that you belong to. And without them, through the pandemic, we'd be in a very different situation. So please do spend some time thanking them as well. I'm now going to sort of hand over to Matthias, who has organized as the chair of the organizational committee. Thank you.
So thanks again for being here. Yes, we are emerging from an unprecedented pandemic, and that makes it somewhat exciting, interesting, and new. During the pandemic, we did ERAS the best we could, right? In trying to treat this new illness, we sought expert advice. We tried to implement what others had success with. We engaged thought leaders and societies, and then realized that RCTs aren't the be-all, end-all, and that's the very best or the very way to get clinical evidence and further clinical wisdom in a short period of time. And COVID obviously had a lot of challenges, presented us with a lot of challenges that we are still working on. Cancel, postponed elective cases, delayed visits, resulting in more patients now who are sicker, more acute. and leading to excess mortality beyond the COVID-related mortality. And when Ole Lundqvist penned this paper last year, he made the point that enhanced recovery really is the answer to maintain regular activity in the operating room whilst dealing with all the challenges that health systems face during a pandemic in personnel-wise, cost-wise, and so forth. And we're doing a good job, actually, because when you look at compliance and outcome of hospitals that do enhanced recovery outside of clinical trials, that's the litmus test. If you look at databases that show what's actually happening, and you see that people have good compliance, over 80% intraoperative compliance, that is great. That is such an achievement in perioperative care. And we can build on that. And we can tackle the new frontiers, which leads me to opening this afternoon's session, which is anything but exciting, super exciting to me, because it really tackles the new frontier in perioperative medicine in the world. And COVID has shown us what these challenges are. Nevertheless, we need to be ready, because COVID is not going to be the last disruptor. There are much more to follow. I think New Orleans experienced that firsthand. So you pick your region, right, based on this map. So not everybody is created equal, and we know this. And there are problems with old, frail people. There are problems with equity and equality. And I'm excited that we have sessions that address these problems, that hopefully give us hints how to get from the specialist consult service implementing ERAS to dynamic risk profiling, and help and add additional help where it's needed to get to equitable care. Because there are problems still, right? This went through the news just a week ago again. Women have worse outcomes after open heart surgery. There we haven't really addressed that fully. And racism issues exist in my neck of the woods in Boston. A lot of people don't even make it to their appointment. So even though enhanced recovery fixes the equality portion probably pretty well, everybody gets the same care, everybody gets a block, regardless of your socioeconomic background, whether you're a woman or man, or your color. But upstream of your perioperative experience, there may be issues, and even if it's just getting to the doctor. Buses in Boston aren't as reliable as subway, trains, and commuter rails. They run less frequently, and there are certain areas in the city that are still underserved with reliable public transportation. So we have the work cut out for ourselves. We need to include considerations for racial, socioeconomic, gender, blindness, and we frankly need to take those blindfolds off and look at it front on. And I think COVID in a way has helped us to do just that. And that is what I have to offer in order to give you the segue into this most exciting session this afternoon. And I have Mike Scott introduce the speakers. Thanks.